Good morning. So today we will go to, we will talk about the gluteal regions as well as the posterior thigh. So because we have a dissection at 1:30, so I think I will stop at like 12:15 so that you guys can have adequate time for lunch, okay? So do I. So we still have 2 more lectures to go. As I gave you like heads up last week, we only have like 8 Canada days to cover 5 lower limbs lectures. It's quite demanding, but anyway, I will actually planning to have like a revision, just like what you have received in your MMG, right? Some revision, maybe online, maybe face-to-face, okay? So to help you revise the lower limbs, as well as for the GI as well, okay? I mean separately, okay? 因為唔係想搞爛 get 啦嚇，即係唔係教腳同教腸咁樣。Okay? If you know it, you know it. If you don't know it, ask your mom and dad. They will know what does it mean. Okay. So this is the learning outcomes. I should upload the answer for these. Think about these questions. So today we have two cases here. Okay, talking about a weird gait, right? Some weird gait. Okay. So what does it mean? Okay, and also this one as well. Again, the posterior hip dislocation. Okay. So basically this one is a recap slide. Talk about the 2 important connective tissues. Here we have the sacrotuberous ligament as well as the sacrospinous ligament. So with these 2 ligaments that form the greater and also the lesser sciatic foramina. Okay? So which act as an important gateways. So through these arrangements, so the gluteal regions can communicate with the pelvic regions, right? With the pelvic regions, as well as to the perineum, as well as with the posterior thigh inferiorly, like these arrows here. Okay. So then we will talk about the muscles. So for the gluteal muscles, we generally divide it into 2 groups. The first group is superficial. Here, the superficial and large, we have the gluteus maximus here, and you can see some of the gluteus medius, and also the gluteus minimus is out of this site. And then we also have another muscles. So the muscles here is called the tensor fascia lata. This one here. Have you seen this muscle before? In other compartment? Yes, because I introduced this muscle with the name only in the anterior compartment of the thigh, which is in L2, right? But this muscle is actually like innervated by superior gluteal nerve, but location-wise, it is in the anterior compartment. So kind of like in embarrassing situations. So all these 4 together, we call it the superficial and the large group. So this one, which is not quite like a trendy, like idol this day, Goigea. And then this one, I've never found any still gay, right? Okay, so and these are the deep group here. So the deep group, of course, we have to remove all these superficial groups so that we can see. So we have the piriformis. You should have heard about the piriformis, right? Because the piriformis is a very important landmark, right, for both the structures in the pelvic regions as well as later on we talk about the sciatic nerve. We will see the piriformis again. So we also have these muscles here. We have the obturator internus, gemellus superior, inferior, and the quadratus femoris. So all these we consider as the short lateral or external rotators. Okay. So functionally, so these deep groups here mainly are the, just mentioned the short lateral rotators of the hip, while this one, the tensor fascia lata, which is these muscles here, okay, through the iliotibial tract, we will talk about it in a minute. Through these iliotibial tract also helps to like stabilize the knee joint in extension. Okay. So let's talk about the superficial group first, the big one here. Here you can see the attachment pattern of these superficial gluteal muscles. For the G-max here, this is the G-max. For the G-max here, it has a broad origin. It has a broad origin. Right, see here is the origin, where the broad origins from the posterior ilium, sacrum, and also the coccyx as well. And then it inserted into two particular sites. The first is onto these gluteal tuberosity. Can you see that? This one is called the gluteal tuberosity. And then it also inserts to the iliotibial tract. Let's take a look here. So this is the gluteus maximus, right? So much of these aponeurosis actually join with these iliotibial tract here, okay? And then this is from the posterior aspect. And then later on we will talk about these tensor fascia lata. Also have the aponeurosis insert, right, to the iliotibial tract, okay? So you will see that this iliotibial tract is actually a passive connective tissues, right? But through the contraction of either or both of these two muscles, that we can exert force, right, to stabilize the knee in particular, if they are working together, okay? And then the gluteus medius. Here is the gluteus medius, okay? So these gluteus medius, we can see these are the proximal attachment site, okay? So we say that it arises from the anterior. So this is the anterior and also the posterior gluteal line. And then it inserted into the greater trochanter. So same as the gluteus minimus. So gluteus minimus is here, okay, between the anterior and the inferior gluteal line, okay? So these are the proximal attachment sites, and then they both attach to the greater trochanter, okay? Now, so the key pattern here is this. So all these three muscles, from the lateral aspect of the hip bone, but their distal attachment sites are not the same. So for the gluteus maximus, the big one here, is go to the femur as well as to the through the iliotibial tract. It will go to the knee as well. But for the gluteus medius and the minimus, it only go to the greater trochanter. Okay. So why I have to emphasize these two? Because later on you will see that actually similar as in the upper limb. Some muscles, if they are just across single joint, that you will predict that only with that joint will have some action, right? Either flexion, contraction, flexion, extension, etc. But if it across two joints, that we have to pay a little bit more attention, okay? So now you may ask whether or not you need to remember all these exact distal and proximal attachment sites of all these muscles. The answer is, it depends. Now, the original ideas of putting all these here is for your better ideas. I would not ask for the exact like attachment sites, because you only have 5 hours on the in lower limbs. So I think it's too much. And also you are not practicing the rehabilitation science. So I think the idea is you better have an idea of like, say for example, this one, the greater trochanter. Later on, you will see lot more muscles that are also attached to the greater trochanter. So you should have this idea. Just like, I would expect you to have the framework of this for your better understanding, okay? So if I tell you a muscle arises from here and then attached to this site, if this muscle contract, if you roughly know the attachment, not the exact site, but you have the framework, you know the ideas, then you will know that this muscle, when they contract, it actually will try to like bend your thigh laterally. So this is abduction. So this is to help you to have a better ideas, not to like remember without any rationales, okay? Unless for some unique muscle, if I explicitly mention about the attachment site for your own good, then you have to be able to tell. I'm a fair person, okay? Okay, so now then we're down to this slide. So in case you are using the old notes, then you have to refer to this new one, because this year I add this new slide here for better ideas. So iliotibial tract. Why I want to mention this, because I think it's better to know it in nature, and then we will talk about the Gmax and also the tension fascia lata later on. Because these two muscles is actually built on this iliotibial tract, okay? So this iliotibial tract, or you can call it an IT band, is a lateral tension band for hips and knee, okay? So it's a lateral thickening of the fascia lata. Remember, we have the fascia lata covering as the superficial fascia, very tough. So this IT band is actually a thickening part of this, okay? The lateral thickening part of the fascia lata. It is not a contractile muscle by itself. So distally, we have talked about this. Distally, these iliotibial tract attaches to the anterior lateral tibia. So this is the tibia attached to this site, okay, which is near the lateral tibial condyle. So this is the lateral tibial condyle. So nearby its structures, okay. So this is it. So I even didn't mention about the condyle, the name of the condyle, so that won't to scare you guys off, okay. So functionally, so these iliotibial tract, it transmits tension. This is a key word here. It transmits tension from the tensor fascia lata as well as the G-mass, the gluteus maximus. So think about it. Emergent, think about it. If these muscles contract, both of them contract, okay? So these will be tightened. And when these iliotibial tract tighten, okay, it helps to, when this tract here is tightened, it helps to further stabilize the knee when it is in extension. Remember, we only have two limbs, right, to walk with. We are not a dog or cat. Very important, when we have to stand upright, when we want to have the minimal effort, right, to put on when we are standing, right? So these soft tissues, right, through the muscle contraction of these two big muscles, that tighten. And then for this side, so that's why at knee, it helps to maintain knee lateral stability and support the knee extension when we are standing, okay? Now to build up with this knowledge, then we talk about the gluteus maximus, 臀大肌. This is actually the official Chinese name. So 古巨基係唔關事㗎, okay. So now we focus on the Gmax, which is the largest and the most superficial muscles of the gluteal regions. So functionally, it is a powerful extensor of the hip joint. powerful extensor of the hip joint, and it becomes especially important when movement such as rising from the sitting position. When you're sitting, right, and you have to like lift up your body, so you make use of these gluteus maximus, or you are 爬山, right, climbing. But if for a very, we call it the silent walk like this, basically you don't have much contraction with the gluteus maximus. Okay, so that's why, that is the reason behind. Okay, so we call it the quiet walking. But the gluteus maximus becomes very active when strong hip extension is needed. Extension, the flexion, extension, right? So you have to do this action, then actually you will have to have a very strong gluteus maximus. So I think nowadays in the gym room, where I even can't find my membership card for a long time. Okay, for the gym room, I guess nowadays the machine that train the gluteus maximus will be the girls' zone nowadays, not the boys, girls, because they may want to have a better contour of the hip. Okay, so that's why, those like climber machine 有啲咪搭，即係有啲 step 行嘅不斷行嗰啲咧，嗰啲係 train 個 gluteus maximus。Okay. So it also helps to laterally rotate the hip laterally rotates the thigh and the hip. So think of this. This is the attachment site on both to the gluteal tuberosity as well as to the iliotibial tract. So think about it. If it contract, so apart from like you like bending a bit like to the back, which is extension. So these muscles here, if you contract, actually we will have can help to laterally rotate the hip, right, or the thigh at the hip joint. Okay, and also the upper fibers can also assist in the abduction, right? Think of it, abduction. You will expel the limbs, right, to the lateral. So a key point here is that much of these gluteus maximus, insert to the iliotibial tract. Okay, so through the iliotibial tract, it also helps to stabilize the extended knee in standing. Okay, so that links these muscles functionally to both the hip joint as well as to the knee. So the nerve supply for these you have to know, right? Inferior gluteal nerve, right, from L5 to S2, and the arterial blood supply come from both superior and the inferior gluteal arteries. You may want to know why. Just simply take a look on the size of the gluteus maximus. So it needs a lot of energy, nourishment. So what's more, remember you also learn about the ischial tuberosity in your year 1, right? So may I invite you now to feel your own ischial tuberosity? Can you? It's the best position where you can feel your ischial tuberosity. Now I'm standing now, so when you are in a standing position, so actually the ischial tuberosity is actually being covered by the gluteus maximus. When you are sitting, you actually like uplift a little bit of the gluteus maximus so that you can feel. So gluteus maximus, the ischial tuberosity. Here I want to highlight one thing. This one. So in this ischial tuberosity, actually we have a bursa. Remember the function of the bursa? You have been introduced with this, right, in other lectures, right? So we have a bursa, right? It's called the ischial bursa. It's located between the ischial tuberosity and the fatty fibrous tissues of the skin. Think about it. If these bursa get inflamed, you may probably have pain, right? So we will talk about it in other slide, in other parts, so that you will have better ideas, right? When someone tells you that, oh, I have hip pain. So how many root cause could it be, right, to lead to that hip pain, okay? So we have the tensor fascia lata here, again. So it runs this one, the muscles here. So runs laterally and is enclosed. So this is the muscles, but it is actually enclosed between two layers of the fascia lata. So TFL extends from the iliac crest and also the ASIS to the iliotibial tract, right? So at the hip joints, this muscle abducts, flex, and medially rotates the thigh. Okay, so it is quite difficult to imagine, so that's why we use technology. Huh? 我頭先 set 咗㗎啦已經。restore. Yes. So the first important action is abduction. Take a look. So this is the muscle we are referring to. So because all the inferior attachment is inserted to the iliotibial tract. So this is abduction. So like you swing, right, your thigh away from the midline. And then, so this is the major action. For the rest of the others two, the flexion and also the medial rotation, they are quite weak, right? Let's take a look. This one. Now I hope you see that when you have to achieve this action, so first we have to bend the knee, and then so that when it contracts, it helps to like medially rotate a bit. But this one is a weak, I have to say weak one. Let's take a look on the other one. This one is also weak. So can you now think of like this action, the hip flexion here? This is why I say weak, right? So what is the powerful or the prime mover of the hip flexion? To assist you guys to do the sit-up. Remember the muscle names? A two-in-one muscle. Iliopsoas. Good. So that's why I gray all these names next to it. I'm not trying to burden you, but I think it's good to know that for this, it is essential. And for the rest, they are not, they are there, but this one only weak and only weak. Okay, very weak. Okay, weak to do this and weak to do the medial rotation. Okay, but it is important when these muscles contract, it exerts the force, right, and try to uplift the iliotibial tract. And it actually tenses the iliotibial tract and help to stabilize the pelvis during walking, and helps to stabilize the knee, we say the extended knee in standing. So the superior gluteal nerve is supplied by the superior gluteal nerve and also superior arterial or gluteal artery. So from my lecture, I sometimes, if I find these attachment cartoon or the diagram good for your study, I will post it there. But I won't ask for the exact location. But this one will be good. Some of you are kind of like visual learning type. So try to look at the diagram more if you find it difficult to remember the names in anatomy, okay? So that's why here you see that this is the iliotibial tract. It's actually the anterior part, the tensor fascia lata, and this one, it is the gluteus maximus, okay? Good. Now, then we're down to another group of muscle. So this muscle is called the gluteus medius, 中肌啦，中肌紅返啲啦呢期啊，中肌 and also 小肌 ，okay， 中肌、小肌、臀中肌、臀小肌 ，okay。So these two muscles, they when it contract, it try to like think about it. This is the muscles here. So when these muscle contract, it lengthen, right? And then so that the whole thigh will become like this. We try to abduct, right? The thigh, okay? So, and also take a look here. The anterior portion of these muscle fibers, they also can help to like medially rotates the thigh. So anterior groups here. So when they contract, it helps, right? Take a look on the attachment side. When this whole bunch here contract, it actually will lift to this side, which is a medially rotation. Medially rotation, okay? So functionally speaking, they are very important doing single leg stands, right? So because we need to like prevent the pelvic drop, we will talk about in the next slide. First thing first, it is supplied by the superior gluteal nerve and also the artery. Let's go to this slide. So when you're walking, so when you have one leg stand on the ground, so these you like the swing leg, that the swing leg, right? You have to like move it forward, right? So think about it. If you stand on one leg, your gluteal regions still are masked, right? We actually have to like make the pelvic supported, right? Lift up a little bit, so that we have enough room for this swing leg to swing forward. If not, if everything keep in the same level, you will like drag your toes, right, through the ground. We need to uplift a little bit of the pelvic so that the swing leg will have the room. Okay. So now you see that this is the action. This is the action played by the gluteus medius and the minimus during walking. So functionally, they are very important because they prevent the pelvic drop on the unsupported side by stabilizing the pelvic on the supporting limbs. Okay. So now you see that when we stand on this leg, right, the stand leg, so the muscle on this side, the gluteus medius and the minimus, they have to work. They have to work, okay, so that to hold, right, or to keep the pelvic level. Okay, this is important because, again, this is a normal one. When a normal person without any problems with the muscles or with the nerve supply, which is the superior gluteal nerve, so this muscle is active, we'll try to pull on this side, okay? We'll pull on this side, and then we keep the pelvic level. What if on the stance leg, affected side here, this muscle paralyzed or doesn't work? So because of the hips, they got weight, and because of the weight, you see that the whole the buttock, right, is like being leveled down, right, like a sagging of the unsupported pelvis. So these feet here will will have a shorter distance to make sure that the swing leg will got enough room, right, to move forward. Okay. So this is called the Trendelenburg test. So you ask the patient to stand on one leg and observe the pelvis. So whether it is normal or negative, so you see level, horizontal level, right, level. So what we see positive Trendelenburg sign, or we say that it is a positive Trendelenburg test, is that you see the pelvic drops on the unsupported side when standing on the affected limbs. Okay, so usually indicates that there could be weakness or paralysis of the gluteus medius or minimus. It is often due to superior gluteal nerve injury. So you may ask, is it common? I can't tell because I can't remember the figures. But some years ago, there is a viral infection called the polio. Have you heard about that? The name polio. polio 即係小兒麻痹症啊。So they are quite common sites to attack the nerve as well as these muscles, so that the people they walk in a they're quite they pay extra efforts to walk. Okay, now take a look here. Now because this muscle is not in good conditions, so that's why you see the pelvic drops. So the swing leg somehow don't have enough rooms. So can you take this side here as a compensation? So if this side doesn't work, the muscles, so it may have not enough room for the opposite sides or the lateral sides to swing forward. What you will do, you will then lean, yes, you will then lean toward the problematic side, so that you have more room for the swing leg to move forward. So that's why please take the image here. This one, you take this like is a compensatory like action, so that to make sure that there is enough room for the swing leg to move on. So the whole body will shift, right, or lean, right, toward the side that with affected nerve problems or the muscle problems. Okay, so in this case, think about, do you still remember there is a term called the center of gravity, the COG? So the whole body is actually to the affected or we so that to make rooms, right? So that it is like compensatory. Okay, now think about if I can't find the old video. I have an old video. Think about if it is so traumatized that both sides of these superior gluteal nerve don't work together. I can think of one cartoon, which is the penguin. The penguin. You will see the penguin walking this way. I will upload the video to the web blog, okay, if I can find that video, okay. So if it is bilaterally involved, okay, so now please have this sense in mind, particularly for the lower limbs action. For some of these important nerve functions, so do pay attention to whether we are talking about unilateral impact, just on either side or on one side, or it is a bilateral impact. Okay, so if this case, the bilateral involvement will cause a watering gait. Okay, I will send you I will upload the slide, the video to Blackboard. Okay, I just can't find it this morning. Okay, so then let's take a look here. So now you have some ideas, right? So what about these deep muscles? So all these muscles here, they are the piriformis, they are the obturator, internus, gemellis, superior, inferior, and also the quadratus femoris. They are very deep. In dissection, some of these muscles, I think you must be able to see the piriformis. For the rest of them, good luck. Somehow it might not be so easy to dissect them out, okay? So they all together, they laterally rotate the hip joint and stabilize the hip joint by pulling. Think about it. One single muscle is not this one single muscle. If all muscles contract in this way, so that it actually bring the whole hips to the midline, which is essential for us as a human. We want to keep the center of gravity, right? The line of gravity, right? In the midline, right? Okay. So what's more, they are all supplied by, okay, for the piriformis, it is supplied by the sacral plexus, and for the rest, they are through the sacral plexus from the S5, S1, or S2. So this one, it's just for your information, okay? So they are all supplied by the gluteal, inferior gluteal nerve. Just for a name, you may see this name in some textbook. So the obturator internus together with the two gemellus, they actually, three of them form common insertion sites here, which is medial to the greater trochanter. So because of these presentation, we have another umbrella terms or collective terms, called it the triceps corsei. Okay. Now this one again, forget about it. No. For the first site here, just focus on the color of the arrows first. Then you remember the names of the muscles. So here you see that this is the axis here. So all the muscles here, like the gluteus medius, the gluteus minimus, as well as the tensor fascia lata, they are all pointing toward these signs. Okay, so altogether they are medial rotator. What about the rest? Remember, we talk about the deep muscles here, right? And also the gluteus maximus. So all of them together, the resultant force is to laterally rotate the hip. So what if they are, so one important point is that with reference to the greater trochanter. So these are anterior aspect, and for these are all the lateral or posterior to the trochanters. So all hip rotators, they also, think about it, individually, they have their own action. What if they are together? They're trying to pull the head of femur better, like stay into the acetabulum, right? So that's why we say this is the strengthening of the joint. Okay, this is important. One of the major issues that we have to deal with for lower limbs, because we have to make sure that our skeleton, remember these skeleton things? If you know that we need to, right, have a very smooth weight transmission and erect bipedal posture, so that's why this particular part here is important. We have to make sure that, right, the limbs, the lower limbs has to stay as close or optimally close to the midline of the body. Okay. So piriformis here, very useful landmark, right? You have learned it in pelvics. So in short, let me say here, above piriformis, superior gluteal bundles, which is the nerve, the arteries, the vein. Below the piriformis, almost everything else. Done. So then the gluteal regions, we have several nerves here. So we mentioned about the superior gluteal nerve. So this one is the superior gluteal nerve. It's applied to the gluteus medius, minimus, and also the fascia lata. So then there is another way for your better memorization. If you can remember the gluteus medius, action of it, and then you can recall it is supplied by superior gluteal, then think about their little brothers, and also the tensor fascia lata. They're all supplied by the same nerve, same action actually. Okay, that will be another easy way to remember. And then we also have the inferior gluteal nerve. So inferior gluteal nerve, nobody but the big brother, the G-max, okay? So pudendal nerve, which pass through the gluteal regions to the perineum. And then another big brothers here is the sciatic nerve, from S to L4 to S3. It passes through the gluteal region to the posterior thigh here. So, and it will later on branch into two main divisions. The one staying medially, we have the tibial branch or tibial nerve. The one to the lateral side, we have the common fibular nerve. Okay, then you see something common, which means that later on it will divide it into either superficial deep or the anterior posterior. Okay, so the sciatic nerve, this is the very introductory for you. The largest nerve, it lives below. Now this one is quite tricky. we say below. But when you do dissection, please have to make an observation. Some people, although they are very aware, the sciatic nerve actually pierces through the piriformis. Variation, okay, variation. So usually it lives below the piriformis, usually divides into the tibial and the common fibular nerve. Now this is usually, please highlight. I want you guys, when you do dissection, so take a look on whether the sciatic nerve, the division point, whether it is near the apex of the popliteal fossa. Some people the division point may be up in the gluteal region. It depends, so it's worth to take a look. So that's why I say division sometimes may occur higher. So we have the sciatic nerve here, the L4 to S3 passes through the gluteal region deep to the gluteus maximus, runs posterior to the hip joint. So this is the hip joint. So this is the nerve. It runs posterior to the joint capsule of the hip joint. You need to border this, because if something wrong with the hip joint, think about the posterior dislocation of the hip joint. If not fracture, I mean the posterior dislocation, if it pushed backward, it actually directly impact on the sciatic nerve, okay? So this nerve then enters posterior to the thigh and then supplies, this one, funny, I find it funny, right? Supplies no muscles in the gluteal regions. It passes through the gluteal region, but it supplies no muscles, right, in the gluteal region. So the motor supply of this sciatic nerve to the posterior thigh muscles through the tibial and common fibular branches, right, as I mentioned here, this one, these two here, okay, these two branches here. So it supplies like all muscles of the leg and foot, right? Skin, right, of the most of the leg and foot. Okay, so that's why you need to think about if there is a dashboard injury. Remember the car incidents, right? So where you sit, your position, where you have your sitting positions, you flex the knee, you flex the hip, as well as you flex the knee as well. When we flex the hip, think about the arrangement of those capsule ligament, whether they are of better protection or less protective, okay? So also think about, well, as I say, these are the piriformis here. What if these piriformis, say, for some reasons, it become bigger in size, hypertrophy? It will also compress or irritate the sciatic nerve, right? So that's why we say that irritated or compressed in piriformis syndrome. Usually we are referring to like the piriformis become bigger in size, hypertrophy. Now, this is an important slide. So now we want to focus on the high or proximal sciatic nerve injury. So as in dashboard injury, okay? So as in like posterior hip dislocation, okay? So if it is the case, then if you know the normal function of the sciatic nerve, then you can recall, so what sort of actions will be weakened or severely affected. So the hip extension weakened, right? The knee flexion severely weakened because of the hamstring muscles is supplied by the tibial branch. Okay, and then the marked weakness or loss of dorsiflexion, plantar flexion, inversion, and all the leg muscle. Remember, we say that it supplies, right, almost all the muscles, right, to the leg and foot. So basically, they're all they have no movement of it. So loss of cutaneous sensation over the leg and foot. Except, now this is the way that you need to know, nearly all these sensations over the leg and foot gone, except the medial area. Why? Because it is supplied by the saphenous nerve, which is with the origin from the femoral nerve. Remember the femoral nerve? The one in the front? They're still working. So that's why this is a unique way to identify the root problem, okay? And because of this, then it will lead to foot drops or the fair foot, right? So weakness in dorsiflexion and weakness in all action below the knee, right? So we will have more elaboration on these, right, in lecture 4 tomorrow, okay? So, but this is a very, like, remember sciatic nerve has a lot of branches. So if we are now talking about the problems up here or proximal in this site, so you think about all the actions, right, carried out by all the branches of the sciatic nerve will be gone as well. But one thing you need to know first, remember we say we have bursa. So here is the bursa. Here is the the bursa nearby the ischial tuberosity. So if it got inflamed, bursitis, or you should know that why we need to have bursa. For those joints that have active rotation, movement, etc., we need to have some cushion put inside it so that to reduce friction. So for here, for the shoulder, we have several bursa related to the acromion, something, right? So here we have the same. Now this one is nearby the trochanter, so that's why we have the trochanteric bursa. So under the G max or under the G medius or the maximus. So these they can also get inflamed. So trochanteric bursitis. But these bursitis around the gluteal region, they may cause hip, buttock, or for the trochanteric one, you may have the lateral thigh pain. So often tender locally, just locally. But this is an important differentiation. But the patient would not complain any motor or sensory loss. Just that you hit the pain point, you feel pain. But the motor function, the sensory of the leg, etc., still there. That will form one of the differentiation, okay? Now, and then for this one, as I said, the piriformis can get bigger in size. So it may irritate, right, the sciatic nerve or have the compression on it. But usually this one will say like, would give like a sciatica like symptoms, okay? So what if we are up to here? So what about we have a herniation of the disc, right? It compressed of the roots, the nerve root. Remember the sciatic nerve is from the L4 to S3. So what if we have one disc protruded, compressed on one of the roots, right? So this one will be the root lesion here, okay? So, but we are only talking about one root lesions, not the whole trunk here, okay? It forms a difference. It is very comparable to what you have been taught, right, in upper limb. Whether or not we talk about the root problem or here we have the trunk, right? We have the trunk here, okay? So that's why we need to protect the muscles, protect the nerve nicely. So in the old day, if you are a fan of Sims, 係咪叫 Simpson 定 Samson 嗰隻好癲嗰隻嘢咧 ？OK。So if you will see that where to have the injection must be to the area which is with the thickest muscle layer or the fat layer. Is it right? No. If you make a cross here, if you pierce right in the middle of your gluteal region, you're actually very likely to pinch on the gluteal on the sciatic nerve. Okay. So unless you are very slim, Okay, unless you're super choppy, like me, I think you have to have a long needle in order to damage the sciatic nerve. But if you are very slim, right, you have a very thin muscles, right, particularly for those bedridden, no much circulation. The muscle probably undergo become smaller in size. So if you have to inject here, you will damage the sciatic nerve. So that's why, to avoid injury to the major vessels and the nerve, particularly the sciatic nerve, the safest place for intramuscular injection is to find these safe regions. So gluteal regions here, they are talking about the arterial blood supply. You have two major supply here, the superior gluteal artery. So the superior gluteal artery, which is above the piriformis, right, supply all the gluteal region, and also it forms the major blood supply to the G medius and the minimus. So for this inferior gluteal artery, which is below the piriformis, supplies again to all regions, mainly to the G max, and also to supply the sciatic nerve. So someone asked some time ago, like, why sciatic nerve need to have blood supply? Of course, it needs blood supply. It's a gigantic big nerve, okay, in the body. So they must have their own blood supply, okay. Now, so remember we talked about the anastomosis in lecture 1. So now we have a recap here. So particularly these inferior gluteal artery form the cruciate anastomosis. With these inferior gluteal artery, with the MCFA, LCFA, and also the first perforating branches of the deep femoral artery, it formed the cruciate anastomosis. The cruciate anastomosis, right? It is around the posterior aspect of the nearby the lesser trochanter. Okay. Now here I just want to highlight one thing. So this is the gluteal. This is the sciatic nerve. So the relationship with the sciatic nerve and also the inferior gluteal artery, or the VAN, always the sciatic nerve come lateral. Medial part, we have the inferior VAN, medial to it. I hope you can see this arrangement in that section, okay? And then also because of the fast demand of blood supply of these gluteus maximus, can you see that these gluteus maximus here, they both receive blood supply from the superior as well as the inferior gluteal arteries, okay? Lymphatic drainage, which is very much the same with the images I showed you in lecture 1. So all these superficial one finally will gain access to the deep inguinal, the deep inguinal lymph nodes, and then they will further down to the internal iliac, and then we'll go to the lumbar, okay? So this is the posterior thigh, the hamstring muscles, right? Okay, maybe I stop here because yeah, it takes time for you to have lunch, okay? So I will stop here. Okay, good afternoon. So today, supposedly on your teaching schedule is the last 2 hours on lower limbs. So, but in the forthcoming break, there are, I can't remember, 2 or 3 societies students, they want to come and have their advertisement. And also I have to leave at sharp 4:30. So if there is anything cannot finish by today, I will upload the remaining video maybe tonight or tomorrow, okay? Now, so let's continue with the posterior thigh muscles, the hamstring muscles. So hamstring muscles here, we are referring to, like, take a look. Number 1, we have the bicep femoris. So I specifically highlight long head here, okay? So together with so these biceps femoris is all running on the lateral side. So they are from the same origin, which is the ischial tuberosity, okay? And then it will descend and then to the lateral part of the popliteal regions. So that's why here also form the lateral upper border of the popliteal fossa. So by the way, this is the popliteal fossa. if you don't know the names, which is the back of the knee joint. And then the next members of the hamstring muscles, we have the semimembranosus. So take a look here. Although this is a 2D image, so can you imagine these muscles actually very thin, running like this? And then the number 3, these muscles with the distal end here, very much like a piece of tendon. So that's why we have number 3 here, semitendinosus. So the 2 is running here. And then number 3 running on the top. Okay. So semimembranosus and semitendinosus. So 3 together, we call it hamstring. So the similarity, they share this proximal attachment site, which is from the ischial tuberosity. And then they descend to the different part of the leg, okay? So for the semitendinosus and also the semimembranosus, this is on the medial side, or the medial side of the leg, okay? So that's why the semimembranosus also form the upper medial border of the popliteal fossa, okay? And then, so these 3 muscles, because they span 2 joints, so that's why it actually, when they all together, these 3 muscles, of course, it can extend the thigh at the hip joint, okay? Extend the thigh at the hip joint, okay? Which means that, what would you do? Extend the thigh. Extend the thigh, right? Extend, okay? So this is called a flex, extend, the hamstring muscles, okay? The hamstring muscles. And then and then as I just mentioned, it also across the knee joint, okay? So you can consider, if we keep this posterior, the proximal attachment site relatively fixed, and the muscle contract in this way, so you actually lift up the knee, the leg. So that's why we say flexes the leg at the knee joint, okay? And the nerve supply is the tibial division of sciatic nerve. Remember, yesterday we talked about the sciatic nerve, and then at the distal end of this nerve, we will divide it into the more medial side, which is the tibial branch, and then on the lateral side, we have the common fibular branch here. So this hamstring muscle is supplied by the tibial division of the sciatic nerve, okay? So remember, why I have to highlight the long head here, because only the long head, strictly speaking, refer to the hamstring muscles. In a minute, I will tell you why. So this image here will give you some ideas about the action produced by the hamstring muscles. Okay, as I said, I try to like give you these kind of diagram so that you can recall the action paid by these muscles. Okay, now, so then here we have kind of outliers. Why? Because this muscle, in 2 ways, it is outliers. Take a look. Sorry, I forgot to mention one thing. So this is I put the colors here to tell you the location of the sciatic nerve. So that's why here you see that the gluteus muscles, the maximus, removed, right? The muscles here removed. So this sciatic nerve, right in upper part, is actually protected by the gluteus maximus, as well as by the long head of the bicep femoris. So these 2 altogether protect the sciatic nerve, okay? Protects the sciatic nerve, okay? Now, here I want to show you the short head. We just mentioned about the long head, so take a look at the short head. So here are the short head muscles. So the short head muscles is here, right, from here. Can you see that? Small one here. The short head muscles. Sorry, the short head muscle is from the bone, from the femur bone, and then attached to the leg, okay? To one of the important sites, which is on the posterior aspect of the femur, which is the linea aspera. So these bone here, so this is the bicep femoris, the short head here. So here from the linear aspera and then down to the fibular head. Take a look on number 1, another number 1, which is this one. This one. So this one is the short head. This one is the short head of the bicep femoris. So what makes it so unique? It is one only cross one joint, only cross the knee joint, and simply look at the actions for these muscles here. When it contract, it will move or flex, right, the knee, okay? And then the nerve supply, take a look. See the nerve supply. This one is supplied by the fibular division of the sciatic nerve, which is totally different from the 3 other hamstring muscles. Okay. So that's why I have to highlight this, because this one, they are supplied by the tibial division of the sciatic nerve. While this one is by the fibular division of the sciatic nerve, which is totally different. Okay. Now the hamstring injury. So if a person that have a certain excessive and forceful contraction of the hamstring muscles, like this one, right, like the splitting or jumping, right, 跨欄嗰啲, okay, they can lead to the following. So first, it could lead to the muscle strain, and then take a look here. It can actually, right, the hamstring muscle, the tendon, remember it is articulate, right, or inserted to the ischial tuberosity. Either the tendon like being torn, right, being torn, or if the tendon is still kind of strong enough, it actually may split, right, or have a small fracture to move, right, part of the ischial tuberosity, right, out. So doing these like injury, okay. Avulsion means forcible separation or detachment. It could be referred to tendon or it could be referred to the bone, okay. It really depends on which one is stronger, okay. And also the direction of the motion, okay. Now here we come to I consider it as a very interesting anatomy structure, which is called the structure here is called the pes anserinus. The pes anserinus. So 3 long tendons merged together. So each of these tendons is actually from like different compartments. Take a look. Let's do a recap. Remember, sartorius is from which compartment? Anterior. Good. And then gracilis, medial. And then we just mentioned about the semitendinosus, which is posterior. So these 3 altogether, they are referring to these a conjoint tendon of these 3 muscles. So where is it? It is on the medial. It's on the medial side. So 3 together. So then you may probably have to recall the sartorius supplied by the femoral nerve, and then also the gracilis obturator nerve, and then for the semitendinosus, which is the tibial branch of the sciatic nerve. Okay, so 3 altogether, they will merge and then form a conjoint tendon, and then inserted to the medial aspect of the tibia. The location is around like underneath the tibial tuberosity. Okay. So give you another image. So this one showed you the medial presentations of the leg, of the thigh. And then we have this one, the first muscle, sartorius. And then we have the second muscles from the medial compartment, gracilis. And then we also from the posterior compartment, we have the semitendinosus. Okay. So why we bother? Because again, these muscles, right? Well, the tendon, because of the muscle contraction, it can help to again stabilize the pelvics and extremities when standing. So those very active sportmen or they like to hike or have the repetitive knee movement. So they may complain about having pain. And this pain is usually because of the tendon in this site, right, have conditions, right? That's why it's called the tendinopathy. So pars and psoriasis tendinopathy. Usually, most of the time, is because of the overuse injury caused by playing sport and required repetitive knee movement. And then take a look. It's actually this is very small, but if you enlarge my note, that you can see that actually underneath these three tendon, cojoint tendon, there is a bursa. Again, if you have to repetitive, like use these muscle and then the involved tendon, right? So the underneath bursa can also get inflamed. That could also lead to bursitis. So that's why we also give you pain, right? So that's it. So that's why this is I consider this one is quite a funny one. Haha. Because three compartments merged together, right? Innovated by different nerve, and then they co-join together. So and again, take a look on the posterior thigh. Let's recap on the neurovascular supply. So remember, for the thigh, right, the most important blood supply is actually from the deep femoral artery. The deep femoral artery. So the deep femoral artery is a thing, but it it relies on the branches here, which is all are called the perforating arteries. Forget about how many numbers. Some textbooks say 3 to 5, 2 to 4. You count it as much as you can, right? You see it when you do dissection, then you know it, right? So particularly here, let me re-emphasize one thing. The first perforating branch here, can you see that the first one, this is the first pair. So actually it contributes to these anastomosis, cruciate anastomosis. Now this one, I hope you can see that it's like a cross. Cross, right? So that's why it's called a cruciate, okay? So the arterial blood supply is from the perforating branches from the deep femoral artery, and then the nerve supply. So the nerve supply, well, remember one thing: the sciatic nerve can have the branch of textbook knowledge is said that it's down to the apex of the popliteal fossa, which is here. So this one gives you the very textbook style, right, of the bifurcation point or the division, nerve divisions. But sometimes it is very high, even up to here, before, right, or pierce through the piriformis. They're already separated into two parts. So that's why if we have to name the nerve supply for the hamstring muscles, so we better say in this way: the branches from the tibial part or division of the sciatic nerve. Okay, so they group together, right? But if like this one, the bifurcation is down to here, but you still see some of these, we call it the tibial divisions, or you can say the medial divisions of the sciatic nerve that supply the hamstring muscles. Supply, be specific, the semitendinosus, membranosus, and the long head of bicep femoris. Only the common fibular divisions of the sciatic nerve supply the short head of the bicep femoris. So this one, now I hope you understand that in each compartment, there must be at least one outliers in terms of the nerve supply, okay? So that's why how to identify these outliers. I like this textbook. This textbook is good in make some drawing, right? So the three watershed muscles. So the three outliers are these three: the pectineus, the adductor magnus, and also the bicep femoris. So these three muscles, they all receive due nerve supply, and they're interposed between the three thigh compartments. Let's take a look. So the pink group here representing the the anterior part, which is anterior group, which is supplied by the femoral nerve. Okay, but we have the patelneus here. Remember, patelneus, I mentioned to you, is quite ambiguous. Some may refer this to anterior compartment, some may refer to medial one. So why? Location-wise, it is in the anterior compartment. But in terms of the nerve supply, it's actually from both. So that's why here you see both. Both femoral nerve and also the obturator nerve supply these patelneus muscles. Okay? And then down to the medial group, very medial, right? So they are all by the obturator nerve. Is there any outliers? Yes, the big brothers here, the adductor magnus. Remember the adductor magnus, there are two parts, adductor part as well as the hamstring part. For the adductor portion, of course, it is innervated by the obturator nerve. But so that's why for the hamstring part, it receives tibial portion of the sciatic nerve. And then we just mentioned about the bicep femoris, right? The bicep femoris. So the whole group of the hamstring muscles, right? The tendinosus, membranosus, and also the long head of the biceps, they're all by the tibial portion of the sciatic nerve. Okay. Just one outline is here, which is the short head of the biceps. This one receives common fibular branches. So I hope these will give you some ideas, right? Okay. And then this one is good for your revisions. Why? Because we finished all the thigh muscles. And the thigh muscles, they are all working together to move the hip. Okay. So this one gives you the ideas about like, that's why I said to you yesterday, and then you don't really need to remember the exact location of this insertion or the distal and proximal attachment, the muscle attachment. You don't have to. But at least you have some ideas about how roughly which part of them are connected, so that to help you, right, to recall, right, the action produced by these muscles. Okay, so let's take a look here. So we have different, I think I won't call the names one by one, right? You can read it by yourself, okay? But you should have very rough ideas about where a muscle starts and where it passes relatively to the hip joint, okay? So think in this way, if here from the front here, right, from the front anterior here, we are talking about the flexion, right? And the posterior, if someone is crossing the hip joint at the back here, you can refer to the action is related to extension, okay? So the lateral means the abduction, like this one, the abduction. The abduction, when it contract, right, it actually expel both the thigh, right, to the side, abduction. And also yep. And the direction of pull on the greater trochanter. The greater trochanter helps you to understand the medial versus the lateral rotation. Remember, we have a slide. Again, that one, I'm not required you to remember all the direction, but at least you know that the attachment sites. So for the gluteus medius and the minimus, right, particularly for the anterior fiber, when it contract, it's actually mediating, right, the hip joint, right, rotate medially, okay? Good. Let's down to some injury-related things, right? I understand that you all love injury, right? Different fracture. Remember we mentioned this fracture some times ago, last week. Remember that? Okay. It's talking about the femoral neck fracture. At that time, I just highlight the fracture site. How does it relate to the treatment plan? Whether or not it will lead to necrosis, right? Remember that? Okay. But now, if we really have the fracture, okay, so how does it look like, right? Think about it. If you are later on, I don't know, first aider, or you are A&E doctor, you call to the site, and then you examine not a body, sorry, a patient, a body lying right in front of you. So you notice that there are some abnormalities of the lower limbs, of the legs, right? So this one is a common one. If you see someone with fracture of femoral neck, so how does it look like? So the leg will actually, now which one is the problematic one? Okay, the left one. Wow, what fancy. The left one. God, left one. The left one, this one. This one is the left one, right? Okay, I'm a left one. Yeah, the left one. Okay. So we have the left femoral neck fracture, and then you see that the leg is actually rotated a bit laterally and being shortened. Then if you're really good at anatomy, then you can explain why. Okay. So two things to go. First, why lateral rotation? Remember we have like a group of lateral hip rotator. Now, this lateral hip rotator is actually balanced, right, by the medial rotator. But now, because of the fracture of the femoral neck, it broken the contact point, okay? Just like this, right? You have the broken part here, right? So this is one thing. And then, so that's why you see that the leg is like laterally rotated. 我冇扮唔到個 body 瞓喺地下俾你睇，OK？會屈起咗隻腳嘅咯，得唔得？屈起啊 ，shortened and laterally rotated. Okay. If someone can help to lie down, I'm okay to put my cam on you, okay, and show you to the whole class. Full pap-noto, you'll be a star. But don't put it on IG, okay? So, and also think about the weight of the leg, right? And what's more, the next slide I just showed you, change in access of the iliopsoas pool. So iliopsoas is a very important, remember, hip flexor. Remember that? When you do the sit up, right? Okay. So this is a contact femoral neck. If there is a breakage, okay, it's actually changed the axis, right? So that's why it will make the leg become shortened as well as laterally rotated. Remember, we have a bunch of muscles, right? Attached to the femur, okay? And also some of them are attached to the leg, right? So because of this, the shortening would due to a pull of all these muscles from the pelvis to the leg. Now, take a look. So say, for example, the muscle B here, the B group, the adductor group here, if the contact point, the axis here break, from this one, now the axis become this one. So if the muscle still keep on contraction, so that's why the lower limbs will become shortened, right, and a little bit flex, right, upward, okay? This is one of the iconic one I want to draw attention.